let's start.
Let's go ahead and get started. Alrighty, everyone. Welcome to Collegial Conversations with Diana Clark. Today's guest is Roberto Olivardia, and our conversation is titled Male Eating Disorders, a Hidden Population. Diana and Roberto, I will turn it over to you.
Thank you, Brandy. I am to have Roberto, I like to say your name, Roberto, on the show, in part because I've raised two sons. I have heard tell of men with eating disorders, but I have not had the opportunity to support or work with a family who is struggling with that particular issue. And I would love to know what brought you to this expertise, Roberto.
So first, thank you for having me. It's great being here. And so my interest developed as an undergraduate at Tufts University. I was a clinical psychology major. And at that time, I was actually really interested in trauma, was sort of my main issue of interest. And my junior year, I took a seminar on eating disorders class. And it somewhat interested me, the intersection of a psychiatric illness with sociocultural influences was just something that was of interest to me. And, you know, it fit my schedule and I loved the class. It was such a really informative class and opened my eyes. And then interestingly, that semester, two fellow male college students, one I knew pretty well, one I didn't really know that well, they didn't know each other, happened to disclose to me that they struggled with an eating disorder and neither of them had told anybody about it. And I thought, oh, wow, this is in the 90s, no internet. So I try to help them go through the yellow pages, trying to get, some treatment and help. And there really weren't many resources. A lot of the programs for eating disorders were for women only. And so for my final paper in that eating disorders class, I basically reviewed the literature, the very small literature at that time of men and eating disorders. And I thought, we need to know more about this. I'm the kind of person that what I love about this field is I'm always looking to fill the gaps and try to learn more of what can we learn more. So I did a senior honors thesis my senior year where I had recruited from men in various colleges in Massachusetts. And I didn't realize actually at the time that it was the first study of men with eating disorders that had drawn them from community samples as opposed to clinical samples. And that really started it. And in graduate school, I continued, whether it was with eating disorders, men with body dysmorphic disorder, men who abuse anabolic steroids, sort of that whole sort of field that culminated in a book I co-authored called The Adonis Complex in 2000, which is weird that was 21 years ago. I don't know where the time goes.
Feel like yesterday.
It literally does.
I know. So can I ask an ignorant question? Where does eating disorder and body dysmorphic disorder intersect?
Sure.
It has two different diagnoses, but for me, in my ignorant brain, they go together. So
yeah, no, it's a great question. So with body dysmorphic disorder is a psychiatric disorder that's characterized by a preoccupation with a part of the appearance, where people will often see that part of the appearance as looking ugly, deformed, very unattractive, and it can range from them perhaps, maybe let's say if somebody does have some acne, but they see themselves as having, much more acne, or sometimes it can be delusional in the sense that they could have the most, the fullest head of hair and think that they're balding. They could be 6'3" and think that they're too short. And it's coupled with a lot of obsessive thinking around that body part and a lot of compulsive or avoidant behavior, things like mirror checking, not going out on days that you fear that body part would be seen. And BDD is not an eating disorder. So, most people with body dysmorphic disorder don't have an eating disorder. However, it can absolutely intersect. I mean, in my view, anorexia or nervosa is a form of body dysmorphic disorder. I mean, because people with anorexia or nervosa who have, when we talk about classic anorexia or nervosa, where they see themselves as looking bigger than they really are, it's basically a body dysmorphic disorder around the whole body. But even in people with anorexia, you'll often see them particularly focus on the stomach or the legs or their face, things like that. But with BDD, it doesn't have to involve an eating disorder, but it's certainly not uncommon, because even if it's not weight related, I've worked with people with body dysmorphic disorder who are concerned about their face and might alter their diet, thinking that that'll change their face or make their facial muscles look a certain way. I worked with actually a young male teen some years ago whose anorexia actually started because he had body dysmorphic disorder over penis size. And he read on the internet that if you lose a little weight, your penis would look bigger. So that started the eating disorder. The eating disorder didn't start from him thinking he looked fat or that he was too big. It really was driven by the BDD. So anyone with an eating disorder should definitely be assessed for BDD, as well as anyone with BDD should be assessed to just make sure that their eating is healthy and not disordered.
That's a great point. What's the prevalence of BDD?
So BDD is much more common than people think. It affects at least, we think, 2 to 3% of the population. And it's gender-wise, it's about a 50-50 breakdown. So just as many men as women have body dysmorphic disorder. BDD is actually a very serious psychiatric disorder as well. It has one of the highest suicide attempt rates. About 17 to 20% of people with BDD attempt suicide. A significant number of people with BDD are housebound because they fear that they look too ugly to leave the house. It could be associated with unemployment. It can be associated with relationship problems. A lot of them actually are single. A lot of people with BDD don't ever get into relationships. It really can wreak havoc. And for people to understand, it's not vanity, that it's not people who are like, oh, all of us, if we could snap our fingers, would change something about our appearance if it didn't. Yeah, exactly. But with BDD, it's a real distortion of what they're seeing, and also a real disparity in terms of the amount of value they place on it. So even like you could still be diagnosed with BDD if, let's say if I'm working with a man who is 5'2", which is shorter than the average height, for a man, and he feels unworthy because of that. Well, he's 5'2", so there's no distortion in his height, but how he internalizes that and the impact that it has on his life could still qualify for that diagnosis, in the sense that, and I have worked with men like that, where they won't leave their house, they have counted themselves out of, like, there's nobody that would ever be interested in me, and those kinds of things could still qualify for that diagnosis.
That makes perfect sense. When you were talking about men and eating disorders, how do the red flags differ? As a mother, okay, I'm sitting here thinking, okay,
Yeah.
how would I have known? I know what that would look like from a female perspective because I know women and I know some of the behaviors, and I've been in a women's room and I've been around women's groups, but I don't know that for men. What are the signs that are different, maybe?
Yeah, it's one of the things that just culturally, we often the fact that we don't think of boys, as even having these kinds of issues, that we're not as sort of attuned, of how, and even boys within themselves, like, and men don't have often a dialogue with other males about these issues in that way. So a lot of times it could be, and sometimes, certain behaviors could actually be rewarded initially without anyone realizing there's an issue. So it could be, let's say the male that I'm working with who's working out a lot, and people are like, oh, they're exercising. That's great. They're going to the gym. But maybe instead of, they're working out 2 to 3 hours, like every day, they feel very compulsive about it. The day of a blizzard where the gym might be closed, or certainly we look at this past year with COVID, they get extremely depressed and very agitated. And you start to think, well, that's a little bit, quite a severe response, to not being able to go to the gym. Where you start to notice sort of restrictive, in the case of anorexia, more restrictive eating disorders of, they're cutting things down, and you start to hear sort of more either it could be negative statements, like I want to change this, want to change that. But I would say for a lot of parents who have sons who have eating disorders, they'll often hear more what they're aiming for, as opposed to, I hate my body, it looks too blank. They'll hear, I want my body to get leaner. I want to have a six-pack. It's more this goal orientation of what they want versus this negative kind of talk, but it's still, I mean, it can still lead them to very problematic behaviors. I want to be, more, developed. I want to be leaner. Boys often don't say they want to be thinner or skinnier for the most part. A lot of the boys that I work with, even the ones with anorexia, they want to be lean. So being overweight and over fat are two very different things with male body image, meaning that like most bodybuilders, for example, are overweight, but they're not over fat. They could be 5% body fat. And so a lot of the boys that I work with anorexia, they don't look as, for the most part, compared to girls and women with anorexia, and that they actually, their body image tends to be more accurate. Like they know that they're very thin. A lot of the boys I work with, they don't think that they're large. And at the same time, they're afraid to eat because they're like, well, if you can tell me that what I eat is going to turn into muscle, then I won't have a problem eating. But I don't know if that's going to turn into fat, and I don't want to have fat. So you still see that fear of fatness, but it's not about the number on a scale though, per se. It's about the body fat percentage that you'll often see. And then in the case of bulimia, and particularly binge eating disorder, I would say really goes under the radar, because think about it. I mean, what do we say about a guy who can eat a large cheese pizza? Is like, whoa, he's like a hearty eater, he's, burly. Sometimes men are rewarded for being like big eaters, in that way. And so some of the men that I've treated over the years will say, no one ever thought it was a problem. They just thought, it's almost like the alcoholic who just parties a lot, and people are like, whoa, he's a party animal. And then, you realize, oh no, this is someone who has a problem. And so for some of the men I worked with, they'll say, I didn't even realize that I had an eating disorder, because no one around me was saying, this is a problem. Like you're eating like a lot, and, and very compulsively. It just gets swept in that other category. So we still need, there's a lot more work in terms of identification.
Mm-hmm. Is the etiology of eating disorders similar between both sexes?
For the most part, yes. What I always tell men that I work with who need more intensive treatment, who need to go to residential programs, that a lot of for a number of male patients, they'll say, well, I'm going to probably be the only guy in the group, with all women. And that's mostly true. That's mostly going to be the case. However, I tell them, you can learn from these women, and these women can learn from you, because there are more similarities than differences with this in terms of etiology. With anorexia, you'll often see comorbid obsessive-compulsive disorder, high perfectionism, high achievement orientation, people who are sort of more heady and less sort of emotionally accessible. With bulimia and binge eating disorder, you'll often see more ADHD, more impulsivity, individuals who might be sort of more externalizing, with their emotions, people who have high time with emotional dysregulation, whether that's in the form of ADHD, which is another area I heavily specialize in. And I see a lot of people with ADHD and bulimia, or ADHD and binge eating disorder. So trauma could definitely be for some individuals, for anorexia, certain sexual identity conflict, whether that's in the form of sexual orientation issues, or just even what it means to be a sexual person. Puberty is very overwhelming for a lot of people. Not only biologically, but also all the rules start to change. And it's like, oh, now there are all these different expectations on me now that I'm this, my physicality is different. And that's just as overwhelming for a lot of boys and as it can be for girls.
Yeah, that makes sense. And there's more information for girls. Girls talk more about that stuff.
Absolutely. That's something that I think when that very first study I did as a tough senior, I remember, proposing this to my the thesis committee, and they were great. They were super supportive, and they said, "But Roberto, just in case, you should have a plan B because you might not get guys. Like A, they might not be out there. I mean, it might not be that common, and B, they might not be willing to talk." So I'll never forget it, and I wish I kept, the little micro cassette of the answering machine, because I had left for that day and I had a day full of classes and everything. And it was this one particular day where the majority of ads were going in all these colleges. And I came home and the 60-minute micro cassette, 60 minutes was full. Now you imagine when you leave a message, it's like a 40-second message that you leave full.
Baby. Yeah.
It was men saying, "Oh my gosh, I can't believe you're studying this. I thought I was the only one. I would love to be part of the study." And they were just talking. Some men were crying on the phone, like thinking, "I have never uttered these words." And so I was the first person that many men had disclosed that they had this problem. They said it's not, it's not something that you sort of talk about with your guy friends. Only in like bodybuilding and sort of high, like weightlifting circles, there's some dialogue, but again, it's not, the language is, "I want to optimize, I want to be bigger, I want to be," as opposed,
make weight for a wrestler.
Exactly. It's not, "Oh, I have a distorted body image," or I feel fat, or I feel like that. There isn't that kind of, dialogue. So that's something. Now, the good news is I have definitely seen a trend with the younger patients that I work with, where they are more open about it with their peers. They have a lot more support from their male peers and female peers around it. So that's great. The older guys that I work with, 25, 30 and up, it's still marked with an incredible amount of shame and isolation really in it.
And are you seeing patients or clients in an even older demographic, 50s, 60s? I'm wondering if baby boomers their kids we know are struggling with eating disorders at alarming rates. Are they also struggling in ways that are being identified, I guess, is what I'm asking.
Yeah, so I have seen men of all ages. In fact, many years ago, I worked with a man who was 70 years old, who had struggled for over 55 years. And what was inspiring is that, he showed you can really recover at any age, because he did recover, and he really invested in treatment. And he passed away some years ago, but he had said to me, not from the eating disorder, from natural causes, but he had said to me, to share that detail that a man in his 70s that I had once worked with can recover, to inspire people that you can never, it's never too late. But yeah, I see men in their 40s and 50s who have struggled for years with it. And, especially interestingly over this last year with the pandemic, and I think with, teletherapy, that's made it more accessible for people, but a lot of people, and men and women, food is, are almost like right under that radar of like disordered eating. And I think with the pandemic sort of really tipped it over. And so I did a lot of work with, people who for the first time were starting to address it. And I think with older people, it made sometimes the body image piece could still be aesthetic, in terms of, wrinkles and graying hair, losing hair, those kinds of things. But it also, body image can take on this form of functionality too, of I want my body to look healthy and to look. And so, there's an eating disorder. It's not in the DSM. It's sort of a term called orthorexia, which refers to people who really want to eat clean and pure. And that sometimes I'll hear from older adults who frankly can afford eating those foods, because to be orthorexic, in a sense, you know, you can't buy organic food on a very low budget. So some of these men, you know, really feel like that, or they get really compulsive about, you know, working out, but it's coming from a place of health, which is a great value to want to be healthy, but it's going, you know, almost too much in that direction, in an unhealthy direction.
Right, right. So I have one question about the intersection between substances and eating disorders. Clearly, substances infuse our culture. It's got to be a co-occurring with eating disorders is pretty frequently, and I've experienced that in our own practice. But what sorts of substances are you seeing as substances of abuse co-occurring more with eating disorders? I'm just curious about that. Yeah.
Sure. That so studies find that one of the difference that men with eating disorders do report higher prevalence of comorbid substance abuse problems than you would see even with women with eating disorders. And I would say particularly with bulimia and binge eating disorder, a very high rate of cannabis dependence is, you know, something that I'm seeing a lot. And, you know, cannabis is one of those substances, because it's, at least in Massachusetts, it's legalized. Its impact and neurological impact is significantly downplayed. I mean, we're in a culture where people think it's medicinal. So not only that they don't think it's harmful, but they think it's actually helpful. And that can, I mean, other than a lot of what it can do neurologically and executively, but it also can mess with metabolism and appetite regulation. And so I would see that. Alcohol, you know, I see use of stimulants, and not from people who have ADHD, who actually studies show when people have ADHD and a comorbid eating disorder, that stimulant treatment is actually helps in the sense of with their eating disorder, because it's managing their ADHD, it's managing their impulsivity. But for people who do not have ADHD, who are using or buying Adderall or you know, stimulant, because it can have an appetite suppressant effect. So those are probably the big ones that I hear a lot about, that I see, you know, comorbid with eating disorders.
Are you seeing an upsurge in methamphetamine right now?
I haven't, and I've heard about it, but in patients that I've worked with, I haven't seen
Not
that.
what you're seeing.
Yeah.
Yeah, I know my goddaughter, who was on our podcast, started out with a serious anorexia and then did some recovery work with the eating disorder, but switched to methamphetamine. It was really fueling the eating disorder in a very different way, but it was.
Yeah. Well, certainly with like things like the impulsive eating disorders, like bulimia and binge eating disorder, that, and this is why, you know, as far as if somebody does have ADHD, is so important to treat the ADHD, because it's not uncommon for a lot of men I work with who either are in recovery for a substance abuse problem, and once they became sober, developed an eating disorder, or the opposite, you know, is this sort of recovery from an eating disorder and the substance abuse problem. And it's that sort of like, almost like an addictive kind of piece that has to be still managed and addressed, that can translate in a lot of different ways. And in the 80s, in the 1980s, they used to have this term called a multi-impulsive bulimic, was this term that was used in the literature of people who presented with bulimia nervosa, who also had problems with substances, who were promiscuous or had sexual addictions, and who had, and frankly, I think we were talking about people with ADHD back then, you know, people who are just highly impulsive, who need a lot of stimulation. ADHD brain is very low in dopamine, which, you know, high carb, high sugar food releases that dopamine in the brain, as what we see, you know, with substance addiction is all dopaminergic. So very, very important, just as a, you know, a plug for people who do have ADHD or have patients who have ADHD, to not under identify or discount the impact that really can have on treatment.
That's really helpful. And I think in an era where ADHD was overprescribed and overdiagnosed, some of us have taken the pendulum, well, it's just ADHD, let's not address that, let's address the other things, because
That's right.
Yeah, I can see that.
Yeah.
So I would love to take questions from the audience if we can. Brandy, has anybody joined us with questions?
We did get one question from the audience, and this goes back to the beginning of the conversation, which was, does BDD tend to be neck up, or does it affect other parts of the body as well?
Great question. So about 50% of BDD is really around like the facial and head area. So the most common manifestations of body dysmorphic disorder will be the skin, hair, the structure or shape of the face, eyes, teeth. However, I have seen virtually every different body part that someone has been preoccupied with. I mean, including elbows. I mean, it can literally affect, someone's arms and in different ways for different people. I remember doing, I did all my clinical training at McLean Hospital, and they have the OCD Institute, which is phenomenal residential program for people with severe OCD and people with BDD there. And I used to run a BDD group. And I remember there were 5 patients in the group, but 2 of them, one was a patient who was very concerned about how pale she looked, and so would compulsively tan and go out in the sun, just wanted to be very, very dark. And next to her was a man who was so avoidant of the sun because he didn't want any, he thought any color on his face, on his whole body rather, would make him look ugly. And it was interesting because they were both, dialoguing like, wow, this is so interesting that you want to be pale. And he's thinking, what? But they were almost trying to learn from each other and realizing that this is the same thing. It's just manifesting sort of in a different way. But genitals, body build, arms, legs, but and people often most patients that I've worked with BDD have multiple body parts that they're preoccupied with, but there's often one that's like the number one. And that usually will be something definitely in the head and face area, which makes sense in the sense that that's what is often seen by other people. That's not to say that people don't have BDD around parts that might not really be seen by other people, but the parts that are definitely viewed by other people are going to often be the ones that you see.
I wonder if people who deal with sexual intimacy issues get more of the responses of body dysmorphic disorder with other parts. The way that somebody would express themselves intimately would differ. Yeah.
Oh, without a doubt. I mean, BDD absolutely impacts intimacy, impacts relationships, and many times with adult men that I work with, and that could be a significant problem in their marriage or relationship, and they don't feel comfortable saying, actually, it's not that I don't love you, or it's not that I'm really, the whole time I'm thinking about, how my butt looks, or how, this looks in my body, or if the lights are off, I'm okay with that. But and especially for men, with BDD, they feel incredibly like they're going to be labeled as being vain, as being like, what are you, crazy? Like, what's going on? Or they fear their sexuality is going to be questioned, that it's very, very, and for women with BDD, there's a lot of shame, around that as well. But for a lot of the men, they are like, oh, I can't bring that up. So it's something, if that is a clinical issue that clinicians see around intimacy, is to inquire, is how you feel about your body. Could that be factoring in any way to this issue?
Right.
We have one more question, Roberto.
Sure.
Can you address the shift in eating disorder treatment in relation to gender identity?
Mm-hmm. So the good news is that now, with our sort of expansion of understanding, and I credit the younger generation really for pushing this dialogue and having us sort of look at gender identity and how that sort of factors into how we even, these constructs of how we even define like masculinity, femininity, what does it mean to be a man, a woman, like it's just putting all of this into this interesting dialogue and conversation. There are some programs that are being much more inclusive too, in terms of looking at whether it's, you know, not just accepting boys, but accepting trans individuals, understanding how, you know, how you identify, the intersection of how that then impacts sort of how you feel about your body. And certainly, you know, our body is this physical representation of who we are. It's not the embodiment of everything that we are in that way. And so that is a really important part of what we have to address in the eating disorder community, is how do people identify and how they want their bodies to align with that identification. And yet we want that, of course, to be healthy, and we don't want people doing harmful things, you know, to their bodies. So we're all about, you know, just healthy ways of, you know, exercise and eating well, and certainly the clothes we wear, and how we might style our hair and things like that. But then obviously, you know, drawing the line of where things get unhealthy. But we do want to listen to our patients around how that could factor in, you know, into their body image.
Absolutely. Absolutely. Well, this has been a pleasurable 30 minutes for me. I have gotten some of my curiosity sated. I have more questions for you. You'll probably be hearing from me as I, you know, think about this conversation and figure out what did I not ask. But
Sure.
you're a wonderful guest, and really appreciate you taking the time to demystify a subject that people just don't talk about still.
Yes, and thank you for having me. And I appreciate you doing this topic, because I'm, you know, I'm always, my mission is sort of continuing to get, you know, the word out there, and having people sort of just talk to each other, and how can we sort of support, you know, everyone who's struggling, you know, with eating disorders, but particularly anyone who's not being adequately identified and diagnosed.
Right, right.